services dataset. I'll be presenting. We've also got a couple of NHS Digital colleagues on the call who are monitoring the chat box. So everyone should be muted. So if you've got any queries, just raise them in the chat box rather than unmuting yourself and speaking. So we have Jonathan Brook, who's going to monitor the chat box from the point of view if you've got any technical issues, if you can't hear or you can't access the slides, he'll be able to help you with that. And we also have Pete Turnbull, who is from the SNOMED implementation team, and is likely to be able to pick up any questions that you have along the way, certain things about SNOMED that you don't understand. So yeah, the chat box will be monitored, not by myself because I'll be doing the talking, but please do use it if you need. There will be time for questions and answers at the end as well. And the general way we tend to run these webinars is that we'll record them. And then at the end, if there's lots of questions that have come up, we'll collate all of those and answer them in a document that we'll publish on the website. Okay, so we've started the recording now. Thanks for that, Jonathan. Everyone should have muted themselves. So I'm going to start. Okay, so hopefully you can see my screen. So the agenda for today is we're going to have a brief reminder of what SNOMED is and why it's important. There's a lot of documentation out there already, and there will be some links at the end of today's presentation if you need to go off and do a little bit more learning. So it will be a very brief overview. We'll look at where you can find the dashboard and how to use it. And then again, there'll be some extra slides on further training and education that you might need for SNOMED. Okay, so let's just start with a recap and an update of why we've got SNOMED and what we use it for, especially in the NHS. So SNOMED is a clinical terminology, so it's a way of describing things that you have done with your patients or characteristics that of your patient. It's standardized, it's global, so several countries use it, and it's the most precise and comprehensive terminology that's available in the world. And it covers virtually all clinical content that you would want to say about your patient in an electronic health record. So it covers diagnoses, procedures, symptoms. If you want to talk about family history, you can do. If you want to talk about allergies, anything that you would normally write in a patient record should be in SNOMED. And if there's not, there's ways of getting it in there as well. So it's a language to describe the interaction with your patient at point of care. And why do we need it? So the hope for the NHS is that the information can be shared between care settings in a streamlined way, so that you can a GP will know, for example, what has happened to their patients in secondary care or in A&E or in hospital. So we need a way of sharing this information that all the systems can understand. So we need smarter electronic patient record systems so that this data can be shared if needed and within the right framework. And so for this information to be shared in that way, we need a common language that all of the systems can understand about the care that has happened to the patient. And this common language chosen within NHS is SNOMED. So it's used, or the ambition is to use it within the whole of the healthcare system. So it's not just for mental health, which we'll be discussing today. It's already been rolled out within primary care. So READ version 2 and CTV3 shouldn't be flown in primary care anymore. We would expect SNOMED. But as part of that, we then need to drive up usage of SNOMED and drive up the right way of thinking about it. And that's part of what we'll be talking about today and part of what the dashboard is designed to do. So we know it's a language, we know it's for use ideally at point of care, and that we're hoping all of the NHS will use it. So that's the kind of starting point. And it works with the classification. So we've got terminology, which we'll be talking about today, and there's also classifications. And I just want to just remind you what the difference is and that they are still both used. So terminology is designed for recording your clinical information in your patient's records. It's very detailed and precise. and it's usually or should be added at point of care, obviously depending on the systems that you've got and the IT that you have within your care setting. And it's used by IT systems to understand the data and to become a bit smarter. And if you're using electronic patient records at the point of care, then you should be able to access all this granular information about your patients to make safer decision makings in real time. Classification, on the other hand, is a way of grouping information into high-level standard groups. So it's designed for providing an overall summary on the episode of care, and it's often added at the end of a clinical episode. So a diagnosis, for example, after many interactions with that provider to understand what's the situation with that patient. It's often associated with statistical analysis and specifically with submissions to the World Health Organization. So we've got terminologies, we've got our classifications, and they work together, or they certainly work together, and we're not trying to replace one with the other. So within the NHS, we've got SNOMED. Both READ version 2 and CTV3 are no longer updated. So you may still have those in patient care records, but new concepts are not being added. So they will slowly become out of date as new things get added. So obviously we're all aware COVID has been taking place. So there's a lot of new SNOMED codes for COVID. There won't be any new ones for READ or CTV3. And then classifications within the NHS, we've got ICD-10 and OPCS4. So one for diagnosis and one for procedures. And they work side by side, but do different things. So you can use SNOMED to generate ICD-10 and OPCS concepts automatically, so there are mapping tables available. And even if you're not going down that route and you have clinical coders within your organisation, then SNOMED can help clinical coders to accurately classify things into ICD-10. And you can also save time and effort that might allow them to feed that information into creating better data quality if they're not having to do so much mapping or manual intervention. So let's have a look at data returns in SNOMED. So what we're wanting to do is in many parts of the mental health services and IAPT, actually, if you're also an IAPT provider, is we're looking, it's already started actually to replace ICD-10 with SNOMED. So thinking about procedures, assessments and diagnoses, where we'll be able to describe exactly what you've delivered to that patient. So using a more granular term rather than one of these grouper terms that are ICD-10. And so trusts should record the SNOMED terms that most accurately describe the care events in as much detail as possible. And this kind of this idea of as much detail as possible, I really hope you can take that away with you, because SNOMED is detailed, and we're trying to help you get good habits, or people within your organisation to get good habits of using the most detailed SNOMED concept that you can. So we don't simply want you to just look at the ICD-10 that you used to send, find an equivalent one and just do it in SNOMED. So we're not swapping one coding system for the other. We're introducing SNOMED because it's more granular. We've got this idea of interoperability between care settings, and we want this idea where if another clinician picked up the details of the patient care records that are using SNOMED concepts, that they would understand exactly what's happened to that patient. So it's having that kind of idea in your mind. Okay, so I want to just introduce the dashboard before we look at it in any detail. Just go over what its aims are. We've done some grouping of some concepts that we've seen within the dashboard, so I want to explain those to you so that when we do the demonstration it should hopefully be a little bit more obvious. So there's two links there. The first link is a direct link to the dashboard, so it'll take you straight there. There's a front page that gives you some information about it, how it was built, and again it talks about these groupings. And then the second link is to the Mental Health Data Hub. So there's a lot of dashboards on there, and if you want to access others, then that would be the place to do it. And the dashboard is an educational tool at heart, so it's to help providers and regions to see and assess the SNOMED that they've been sending to us as part of the mental health dataset return and see if there can be some improvements. So it's a tool to help you see how you can get into these good habits of using SNOMED in the right way. From the dashboard, we can see which providers are submitting any SNOMED. So we look at the fields, is there any data in there at all that could be SNOMED? And then for procedures, we've made some assessments of where improvements can be made. And for assessment scales, we've also made some suggestions of where perhaps providers are not flowing this information to the right place within MHSDS. And this will all become clear when we go through the dashboard. So the dashboard is looking to assess, basically, are you using the right part of the SNOMED hierarchy? So the SNOMED is split into different hierarchies to do different things. So there's a procedures hierarchy, there's a diagnosis hierarchy, there's a body parts hierarchy. So are you in the right ballpark? Are you in that right place within SNOMED to what you're trying to say? And we've made some assessment on that based on something called a semantic tag of the fully specified name, and we'll look at what that means. And then are you using SNOMED at the right level of detail? So trying to avoid these group terms, but giving as much detail as you can about the level of care that was given to your patients. And then has this been recorded in the right place within MHSDS? So I appreciate these are different things. Maybe some are recorded at point of care, and then maybe there's some automation behind everything, or some manual intervention to get that into MHSDS. So where there may or may not be some work to do to improve things will depend on how you've got your system set up. But for example, are we seeing things like diagnosis in the procedures part of MHSDS? So these are kind of hints, things that we're going to look at in the dashboard. And one of the things we're going to focus specifically on is procedures as part of direct care. So we've got a table called care activity. It's a 202 table, and within that there's one specific field called code proc and proc status. So this is to record procedures and interventions. And we have taken all the SNOMED that we've seen since April. I think it goes till December provisional. We haven't updated it yet for final. So it takes all that year-to-date data, and we've categorised it into five broad categories. So these are the categories. There's two where we're saying at the moment there's nothing to do. There's nothing for you to do from a provider perspective, or nothing to think about. So it's a correct hierarchy. You're in the procedures hierarchy. You're in the right place. That's okay. Or maybe you've sent us some post-coordinated concepts. So this is the idea of used in the right way, joining some concepts together to give a little bit more granularity. So, for example, you might want to say that a procedure was declined. So you can use several concepts to be able to say that. So that would be something that's post-coordinated. And we've not assessed that yet to see if that's been done in a sensible way or not. But what we have done is we've looked to see if some of there's these group of terms, and maybe they're too generic. So working with terminologists who have been working in the mental health field, we've come up with a list of generic SNOMED concepts that we think there would be something better out there for you to use. So this is just a starting point. We're very open to feedback. This is not a tool to kind of say where things are wrong, but more to help you getting in that mindset of granularity. And maybe there's really good reasons why you've used certain group of terms. Maybe the thing that you wanted to say doesn't exist yet. So we're very much open to feedback on that as to why that has happened. And then there's an email address as part of the database that you can get in touch with us if you need to. So that's the two generic group of terms. There's a group where we say it's for review because it's not a procedure concept, so we think you're either in the wrong part of SNOMED or you've sent it to the wrong part of MHSDS, and again we'll look at some examples of that. And then there's a final group where it's not a SNOMED concept, either because you've given us READ or CTV3 by accident, or perhaps something has gone wrong in terms of the code that you've given us. So I'll just show you these three review buckets in a little bit more detail, and then we'll jump into the dashboard itself. So these are the ones that are too generic. So we've seen that providers are using this, either a lot of providers are using these, or maybe just one or two are using them, but a lot, quite extensively. And as I said, we worked with some terminologists who know SNOMED very well, and also the area of mental health. So this first grouping, they've all got a lot of descendant concepts available. So we would hope that there would be something available to you that is a little bit more detailed, that you could say what's been happening to your patients in terms of the procedures that you have been undertaking with them, on the interventions. And then the bottom group, they generally don't have a lot of child concepts, but there was likely to be something a little bit more detailed available elsewhere within the terminology. So we'll look at some examples of these in the dashboard. So the second category, where it's not a procedure concept, so we've looked at something called the fully specified name, where it's got these brackets on the end and tells you where in SNOMED you are. And so if it's a procedure, we would expect you to be in the procedures hierarchy, or in the situation with explicit context hierarchy, where you might want to say a procedure where there's pre-coordinated concepts that say, actually explicitly say a procedure has been declined, or maybe there's a procedure of talking to a patient's carer, so it's that person is not that directly involved. So we've said if it's not in one of these particular places, then we think probably you're either in the wrong part of SNOMED, or the concept is in the wrong part of MHSDS. So it's these three semantic tags at the bottom: procedures, regime therapy, which is a sub-hierarchy of procedure, or situation, which is this situation with explicit context hierarchy. I'm not sure you'll be able to see this slide necessarily, but you'll have it to take away with you, and you can zoom in if you need. And there's a link to this SNOMED's hierarchy fact sheet. So it gives the most commonly used hierarchies and a little bit more information about them. So just to kind of help you on that journey. And then the final grouping is that it's not a SNOMED concept at all. So maybe it's CTB3, maybe you've been using Excel. If you do use Excel, then the SNOMED concept can be quite long. So unless it's a text field, it'll convert it to exponential and you'll lose your last digit. And then when you send that to us, we can't find it in the reference data. We don't know what it is. So just be careful of that. And if you do manually enter any of your SNOMED concepts, then the term browser can be a good place to start to see all that is available to you. Okay, so that's kind of a bit of a whistle-stop tour of SNOMED and the way we've been looking at it. So let's dive into the actual dashboard itself. Let me just go to the front page. So I'm hoping that you can all see the slides. It's not the slides, sorry, the actual dashboards. So if you can't, I'm hoping someone will pick that up in the chat and let me know. So this is the front page. It gives a little bit of explanation as to the dashboard. We've got these different parts of the dashboard that we can look at, and we'll also look at some of these symbols that do pop up in different places that give you a little bit more information about what you're seeing. So I'm just going to use these arrows at the bottom to just cycle through the pages. So the first page is just a general overview. So if you're a regional manager and you want to see which providers in your area are giving us any SNOMED, then this is the place that you would go. There's been no assessment on this page of if the SNOMED is any good or not. It's just we've looked at all the fields within MHSDS that accept SNOMED and look to see if there's anything there from April last year. You can filter by region, so I'm going to filter, I'm going to do the Northeast because I live up here. So let's have a look at Northeast and Yorkshire. It might be a little bit slow because we're just sharing it across the network. So if I'm just looking at, I'm just interested in this region, then I know out of all my providers, there's 39 that do submit some SNOMED or have done since April, but there's 19 that haven't. Here's my list on the left of all those who have submitted it, and the number of records that each one have given us, and the system supplier. And then over here, these are the providers who haven't given us any SNOMED to date. You can find out what type of provider there are, if they're independent, NHS. And further down here, we can see all the different parts of MHSDS that accept SNOMED. So I'm just going to actually take that filter off so we just see everybody. So this is the SNOMED, this is, sorry, a table within MHS, and this is a field within that table where we expect some SNOMED to flow at some point. And so what this little table here is telling us is that if we were interested in the care activity table, there's 3 fields here that accept SNOMED, and we can see that this code proc and proc status, it's since April there's been over 7,000 different types of SNOMED concepts submitted to that table. There's over 13 million records, and 107 providers have given us some information there. You can see that actually this 802 cluster table, although there's less variation, there's just 1,000 different types of concepts sent to that table. It has by far the most volume, 146 million, but only 59 providers. If you're a provider or even a regional lead or just someone interested and you know you want to start, for example, sending data to some particular part of SNOMED, MHSDS, and there's not many people doing it and you want to see what's going on, then you can click on here. So if I was interested in, for example, previous diagnosis, I could click on that field. I know there's 2 providers who are sending us that. And these are the 2 providers who are sending us information about previous diagnosis. And you can do that with any of these things here. So in your own time when you're using this dashboard, I really would encourage you to kind of click around and see what you're interested in, because it is interactive between all the different parts. So this is very much seen as an overview. We have included system supplier. So if your system supplier is potentially giving you a bit of pushback, or it's not working in the way that you'd like, there's the option to see which other providers are using that same system supplier. And that information comes from the MHSDS submission. It comes from the most recent one. So if that's changed recently, it'll only show the most recent system supplier for that organisation. Let's say we're interested in just looking at all the providers who have, let's see, we're going to go for Paris. So we can just click on that. Okay, so I haven't done this one before. So interestingly enough, Paris, everyone is submitting to MHSDS. You can see all the tables that they're submitting to. There's 7 providers, and yeah, again, care clusters is the biggie. All 7 are submitting to the procedures table, so it can be quite detailed as you need. Okay, I'm gonna, if you're playing around with several filters, you can use this reset all filters button here up to the top, just to kind of bring it back to basics. I'm just going to come back to another region, so let's pick the Midlands for now. Okay, and I'm going to take us onto the next slide, onto the next page. And you can see that the filters stay. So if you're interested in one particular area, it can be a region, it can be a provider or a system supplier, then you can put that on the first page and it carries through to all but the last page. But I'm actually going to reset filters for now. Oops. So we are diving now into the procedures, into this 202 table, this one particular field where we've attempted to group the concepts into meaningful buckets. So this looks generally overall at what we're seeing in MHSDS. So I think it's quite helpful to see a distinction between the number of distinct concepts that we're seeing, the different types of SNOMED concepts, and then the volume. So over here we've got the different types. So we've got these 15 generic and 2 generic. We've got over 700 that are they're not a procedure, and there's over 200 different flavours of not a SNOMED concept. We've got a little bit of post-coordinated, but like I said, we haven't assessed that at all. And we've got all these that are in the right hierarchy. What I would like to say at this point actually is that these 15 that we've picked, it's likely to grow over time or change. You know, this is very much an introduction to or a first step towards using SNOMED in a more useful way. And making sure we're at the most granular level. So as we start to work more with terminology specialists, the use of these generic concepts may alter. We might add some extra ones into that particular bucket. And you can filter as you want. So down here it's currently filtered to those that are used the most. So the highest used one is something that's too generic, and it's evaluation procedure. So we don't really know what has happened to that patient. We just know some evaluation has taken place, and there are a lot more detailed concepts that you can use. I think there's over 300 or so, and 34 providers have been using these. Let's look at the most commonly used one for all providers, so cognitive behavioural therapy. So 70 providers have been telling us about this, and we've said it's in the correct hierarchy. And I know this is quite detailed. I don't think there's that much below that. So yeah, I think it's probably one of the EIP concepts. So it's been used well so far as we can tell at the moment. Here we have included filters for months. So if you're interested in a just particular month, that you can filter on that. We'd expect, if you want to give feedback on how useful things like this are, please do. So if there's something that you particularly want to dive down in, you can again pick on a certain provider in here, but what I really want to spend a little bit more time on is the next page, where we can look at providers in more detail, and we can look at how you can look to fix things should you want to going forwards. I just want to point out these two little icons here. So the question mark one, if you click on that, it will take you to another page where again it just explains these groupings that we've talked about, and it reminds you of how we've identified the two generic ones. And within that, it gives you a little bit of advice in terms of how you can start to think about things in a different way. But we'll go through that here today as well. The information icon, if you hover over that, it will tell you, for example, here that you can click on a category and it will filter the results, and you can click again to deselect. So let's just click on this two generic one. So these are all our 15 concepts that we've said are too generic. We can see how much they've been used overall, and we can see how many providers are using them. And then we'll go and dive into the next page and see a little bit more about how you might use this as a provider. So if you yourself are wanting to see how you can, what you've been giving us. So this is kind of the same information but displayed in a different way. So we've got all the providers on here with those same categories. So how many providers there are submitting procedures, how many providers where there's some action to take potentially should you choose to, and the number of concepts where there's something to review. So it's these review buckets really. So we can see TZESC and WIA send quite a lot of SNOMED. Majority of theirs is in the correct hierarchy. I just want to point out I'm not picking on any provider for any particular reason today. I'm going to try not to do that, but if your name pops up, that's just the way it is, sorry, but it's certainly not preempted in any way. So yeah, we can see what's going on here. So let's just have a look. If you were Greater Manchester, if you were Greater Manchester and you wanted to see all of your concepts where we've said you might want to think about having a look, if you click on that one, or you could have selected yourself from the provider list at the top, then this table at the bottom shows you just the concepts where there's things to review. It doesn't show you the stuff that we've said is all right. It just gives you all the concepts where you might want to think about reviewing something. So nursing procedure, that's been used quite a lot. Mental health, all these are very generic, been used quite a lot. And we're going to look at some of these in a little bit more detail about how you can alter them. I'm just going to click on that one again. You can scroll down this chart, and as it gets a little bit smaller, just use this bar at the bottom to bring it in. So let's look at this one, Lancashire. So here's Lancashire's. If you were Lancashire and you wanted to take this information away with you, this is going to tell us that if we hover over this table, you get 3 dots, and you can right click and you can export this information. So this isn't available on all tables, it's just for a couple. These dots are not going to appear now, are they? Maybe this is something I need to sort out, but there should be 3 dots that should appear here, and you should be allowed to export that. Maybe it's because I've zoomed in. Let me just check if that's to do with it. No. Okay, I'll make sure that's fixed in the live version. But what it allows you to do is download a CSV file. So you've got that for yourself, and it has all this information in it. So you've got your list of the concepts, what the category is to help you think about what you might do. So I'm just going to go back a page for a moment, and let's just have a look at some of these categories. So let's have a look at this evaluation procedure category and understand why perhaps this is not the best one. So I'm just going to go into this term browser. I'm just going to clear that I was looking at earlier. So this, if you're not familiar with it, there's a link to this in the slides. There's a link in the dashboard itself as well. Really handy little tool. So these are all our SNOMED hierarchies. So you can see at the end, they've all got these names in brackets. So these are the semantic tags where you can, it just tells us where we are in SNOMED. So you could expand any of these things and kind of dive down, but the best way really is to use a search function. And you can search in here and you can type as little as you want. Type very badly evaluation procedure. Right, so there we go. So this is the evaluation procedure that we've seen many providers are giving us, and there's at least 325 children of this concept, of which a lot of them have more children. So there are a lot more detail that can be used there. So in instances like this, where we're seeing a really high level group of concept used, we can't really offer any assistance in terms of what you should be telling us, because we really don't know, because it's so high level. Depending on how your organisation is structured, that might be to have some conversations with your system supplier around the fields, the SNOMED that you have available to you when you're trying to input this data. If you're an organisation who has created your own drop-down lists, then maybe there's some work to do there to try and find common things that are detailed that you want to say. But yeah, we've got this evaluation procedure that we can see is really quite high level. So what else would we want to have a look at? So there's this treatment given. So again, this doesn't really tell us very much, but you can see this is in the situation with explicit context hierarchy. So again, what treatment has been given? Perhaps there's something a little bit more detailed that you could supply to us that would be much more useful. So it's about thinking what for these too generic, what more granular things can be used. Okay, so let's just click on this not a procedure concept. At the moment, so all of this will change. So we know these system suppliers are giving us some of these things. So if we were to think about, again, looking at this this semantic tag, this brackets at the end of the fully specified name. So none of these are in the procedures hierarchy or the situation with explicit context hierarchy. So because we're looking at this here in this one table, we're being quite specific. So we're starting just in one place in MHSDS and been drilling down to show you how you can maybe make things a little bit better. So we're in the procedures part of MHSDS, and we're seeing things in there that are not procedures. So this screening, perhaps you're wanting to say that you've done a procedure of screening, but that's not what this concept is telling us. This is a qualifier concept. So it would be used with another concept to say, we've done something which is a screening. So you wouldn't really use that on its own. So let's just have a look back in here. I'm just going to. All right, so screening, and you can see the first one actually does pop up is a qualifier value. So over here, we can say actually I'm only interested in things from a certain hierarchy. So I'm just going to click on this procedure here, and you can see these are all the different screenings that have popped up. So maybe there's something in there that you are actually trying to tell us about the screening that you've done with your patient. There's quite a lot. So obviously I don't know what you were trying to say, or maybe it doesn't exist, which is why something like that has been picked. But hopefully there would be something once we've had a look about, let's have a look at health screening. And again, there's quite a lot of subcategories there, lots of children that could be used instead of this this wrong part of SNOMED. Same with other. On its own, it really doesn't tell us anything at all. And at this point, actually, one thing I do want to say is what we have done is look at all the SNOMED concept that we've seen in isolation of one another. So we haven't, because that's generally how we see in the data flow. So there might be a handful of providers who are giving us, for example, for one care contact, several SNOMED concepts, because you've done several things, and so if we were to look at them in one big block, it would make a little bit more sense. But we're not seeing that as a general habit of providers. What we're more seeing is same concepts used over and over again, and so we're just trying to have a look at how we can make those better. So we're looking at everything in isolation at the moment. Let's have a look at this one here, clozapine monitoring. So I suspect that what someone is trying to say is that they've done a procedure where they've been monitoring this in their patients. I'm just going to go back in here. I'm just going to take off all of my filters. I'm only typing in a little bit. Here, the only thing that pops up at the moment is this something that is a procedure, but that's because I'm only showing active concepts. So if I was to show inactive concepts as well, then we find this concept that we found that's been sent to MHSDS, and it's a finding. The pink means it's inactive, so it's been retired as a SNOMED concept. But the principle behind what it means, having this bracket finding at the end, is still useful to talk about. So having finding at the end means, as a clinician, you've found that clozapine monitoring is taking place. It's something that you've seen in the patient, or there's something that's seen, it's happened. It isn't something that is being done now. It's not a procedure that's happening now. So in this case, there is actually a concept that you would want to use, which is this regime therapy, medication monitoring for clozapine. So yeah, that's what would be the most appropriate concept to use here. So hopefully that's helping you understand a little bit more about the different hierarchies to use. Let's just briefly look at this. Not SNOMED concept. So what we've done is taken the IDs that we've seen, tried to find them in the SNOMED reference data, and we can't find them. So I think for a lot of these, it's because they've lost the last digit, because they've probably been using Excel or something like that. And so in your page here, when you're selecting yourself as a provider, all of that will show here. So you've got that to take away when the 3 dots start to work. Okay, I think I've probably covered quite a lot in terms of using, thinking about SNOMED detailed, thinking about using the right part of SNOMED, thinking about making sure it's in the right part of MHSDS. If you're wanting to see just from a time point of view, just generally in the procedures, how many records have been sent by each provider, maybe you're a regional lead and you want to see how your provider is growing over time. We can see that here. So just 42nd Street, for example, they didn't send us anything. And then they've started since July last year to send some data to this care activity table. Here, we've not made any assessment of these 5 categories. We've just said, OK, there's something there. They're trying to get it right, even if there's some work to do on that. And that's in the other pages that we've looked at. So, yeah, this is just more for background. Again, you can click on, let's have a look at care notes in this example. You can click on a particular system supplier and you can see out of all of their providers, which ones are or are not sending SNOMED to us. So it's not always a clear-cut case as to where the work needs to be done, either with the provider or with the system supplier. Again, you've got all your filters as normal, region, provider, system supplier, month in this case, should you need it. Okay, and then so let's go on to one final page, and this is to do with assessment scales. So within MHSDS, within the technical output specification, there's lists of assessment scales that can legally be sent to the mental health services dataset in a couple of places. So they should be sent 606, 607 and 802 tables, just 3 tables that they can be sent to. And there's validation rules around that. So if you try to send anything else to those tables, it would kick it out. Whereas there's no validation rules about where you could potentially put it somewhere else. And so we are seeing that there's just a small number of providers who have been sending this information to the different part of SNOMED, and primarily care activity and indirect activity table. There should be 3 dots above here as well. I'll need to sort that out. But again, this would be a table that you can download yourself. If you're, let's have a look at just one provider, a small one. So they've just got one concept actually that they've sent many times to the 202 care activity table, and we would have likely picked that up actually in the previous pages where we've said this is not a procedure, so it's in the wrong place. Again, we can see which system suppliers. So if you're just interested, for example, in all the providers who use System 1, I think there's probably just about 2 of them. Let's just scroll in a little bit. Oh, there's 3, there's another one down there, who are using System 1 and sending some of these assessments to the wrong place. Just got a couple of icons again. So just to highlight that the filters on this page are not synced to the other pages because there's only a small number of providers. So we've just kept it just to those providers in question that might need to look at this information in a little bit more detail. And then again, there's another help page to give you a little bit more information, and that doesn't seem to be working, unfortunately, but it should link to another page about assessment scales, pretty much like the other one did about procedures. So it gives us a little bit more information about where it should flow, where to go within the MHSDS technical output specification for a little bit more detail. Okay. And so I'm just going to pop back onto the slides. Just a couple more I want to cover before we just see if Pete wanted to address anything as part of the questions that had come up in the chat. So that's the link to the dashboard, the live dashboard, where I know I need to alter a couple of things. And we do know that absolutely in the pipeline, there's definitely a few more things we want to add. So we've already started work on this actually, and I might have spoken to a few of you about early intervention in psychosis. And what we're looking to do is add, so for both early intervention in psychosis and children and young people with eating disorders, there's published SNOMED concepts around what interventions would expect clinicians to use for those cohorts of patients. And so we can then look at the data that's come in within MHSDS compared to that list and see which providers are using which ones, see what else has been used. So it's not necessarily a right or a wrong. It will help policy as well understand, for example, that even though it's not classed as an intervention to use, every provider is using a particular intervention because it works. So this will give us an insight into which interventions have been used most frequently, which providers are not recorded any of those at all, and maybe that's a recording problem rather than a clinical problem. But again, used as a tool to help you understand what should be recorded and where within MHSDS for these two things. As I've said, this dashboard is very much in its infancy, so it will grow and change over time as we realise what people need to make use of it to help them the best. And at the end of today's presentation, there will be a survey. And one of the questions on there is, what else would you need in the dashboard to help you? So if you've already got ideas, please do use that box because it will help us. Okay, and then I've just got a few final slides, more for reference really. I don't necessarily need to talk about them too much at this point in time, but just to say that in the NHS Digital SNOMED website, there's a lot of educational resources, there's case studies of providers who have implemented SNOMED, and there's discussion groups, and there's a lot of technical guidance and documents. So the main link to that homepage is at the top. Or you can just search in Google for SNOMED Dellen. And then there's a couple of other pages that I've specifically just pulled out that will help you. So SNOMED in mental health, the training and educational site, there's quite a few just small videos. There's also that link to the hierarchy spreadsheet that we saw. And there's the direct link to that term browser that I kept popping into to have a look within SNOMED. For concepts that are available. So that's the end of my presentation. I hope people found that useful. I know there's been quite a lot of chat. I haven't been able to monitor it because I've been looking at the slides, but I'm just going to ask Pete if he wants to address anything, that's any key themes that have been popping up, if you want to share that with the group at all, or if there's anything that we'd prefer to just answer in something that we'll publish after this presentation's finished.
Thanks, David. Oh, I've got a bit of echo there. Could you possibly go on mute?
Yes.
Excellent. Thank you very much. Yeah, so thank you all for your questions. Just to explain who I am, my name is Pete Turnbull. I run the SNOMED CT implementation support function at NHS Digital. So I can answer your technical SNOMED questions. For the more MHSDS specific questions, I'll leave that to my more knowledgeable colleagues. A few things on this. The first thing, and this is something that comes up a lot, is about pre-coordination versus post-coordination. There is an answer in chat, but just so you've heard it. When you look at a single SNOMED CT concept, we call that as a pre-coordinated concept. A clinical author has captured an entire clinical meaning and they put it in a single concept. For instance, there is a concept which is breast screening offered, and that's a single pre-coordinated concept that comes out with the terminology. But these things, where they have a status like offered or declined or refused and that sort of thing, historically some of these things exist. But more recently, we're trying to move away from that as a way of authoring stuff. So the way that you create that is you can connect together SNOMED CT concepts to infer more meaning. And this connecting together of concepts is called post-coordination. It's something you do after we've released the terminology, hence post. So you can put together the concept for smoking assessment, the concept for a procedure context, and a value attached to that of offered to create smoking assessment offered. Whilst this is all possible, there are massive technical and clinical safety implications of using post-coordination. If you want to do it for a data return at the end of your episode of care where you're just submitting your data return, that's fine. If you want to put it into your EPR data, speak long and hard with your clinical systems supplier and invite myself or my team along to have a chat and support you in that, because the technical implications of post-coordination are broad. I suggest if people are interested in this more, then via Claire we can set up another session and we'll talk about post-coordination in more detail, and we'll give you some information on it, and we can have a chat about the sort of knock-on effects of post-coordination and what it means. But pre-coordination, single Snowman CT concepts; post-coordination, concepts connected together using a specific type of syntax and a whole set of rules to add extra information to what we call the focus concept. So the focus concept for smoking assessment would be added to and post-coordinated to say that it was offered or declined and that sort of thing. Things about levels of detail. The big thing to bear in mind really is what we want from yourselves is for you to feel empowered to record the most granular level of detail that most accurately describes the care that you were given or the outcomes of that care, or whatever you want in your EPR. My focus and the focus of getting SNOMED in the NHS isn't actually to do with data returns. It's to do with getting quality data into the EPR for the purposes of better care and the better support of people giving that care. What comes out of that, we hope, is that data returns sort of fall out for free from that. The difference really with the MHSTS is that was driven by a data return rather than driven by quality data in the EPR. And there's a really, really good question, if I can find it, from Rachel Moody, who says, I found providers code sufficient info to generate income. What is the incentive there to improve the depth of coding? That is difficult for us NHS Digital to do as a technology provider from the centre. What we hope, and what I know that you will do because you're all care providers, is that you demand that of your systems supplier when you're specifying systems and when you're commissioning systems, that you say of your system supplier, our level of compliance for SNOMED for our organisation is that we can record all the levels of detail we need for the care of the people that we are concerned for. And you drive it that way through your own requirements. If you want help in specifying those requirements, again, get in touch with us and we'll try and help you. But the need for high quality data in the EPR and the need for suppliers to give you systems to do that needs a conversation between care providers and system suppliers, which we're very happy to facilitate, but you need to drive because you're the experts in the data you need. We're not. We are the creators of the technology, not the experts in your area of care, but we will support you in defining those requirements if you let us. Just scanning down some more, I think that was about it. Oh, are there any plans for further reference sets to be created? There's a few plans for this. One of the things that we'd like to do is move people away from the need to have nationally published ref sets, but give you a platform to create and share your own value sets. There's something called the terminology server, the Onto server, which enables this. And there'll be more information about that in the coming months, but we can send you some links. But what we would like to do is, say you are in, picking someone at random, Dorset, and you have created a value set for your eating disorder treatments, and you think this is really, really good. We've got the precise accuracy that we need to use. We've got a really good set of data here that we can build our forms and our templates with, and we can write our guidance on and all that sort of stuff. We want to try and give you the ability to publish those so someone else can find them and download them and use them, and maybe even comment back to you and improve them, and then you can take the improved version back. So there is technology coming that will hopefully free you from the shackles of having to wait for us to design a reference set for you. There'll always be plans for new reference sets. We get requests for new reference sets often, probably 2 or 3 times a week through the request portal. We don't action all of them for various reasons. Some of them we do action, but then they take a long time to produce because we need clinical expertise like yourselves to tell us what should be in it. But what we'd like to do and what we're going to do is free you from the need to wait for us to do a reference set by giving you the tools and ability to not only create, but share and curate and improve your own value set. Following on from that, actually, Lauren Cartwright writes about people are giving up trying to find relevant codes. There's a lot to be said about how codes are found, and that comes down to not only user training and expertise, but also interfaces and having easy ways of finding those codes. We do have some training on searching in SNOMED and effective searching in SNOMED and making searching in SNOMED quicker by the use of filters, and we use our online browser for that, but it would also apply to a system supplier's implementation. But there is training available, so if you are in a situation where you are struggling to find what you need and you want a bit of help, again, get in touch with us and we will help you, but also we can signpost you straight away to some recorded webinars and presentations on effective searching in SNOMED to find what you need. As a rule of thumb, there are two basic things that really help everyone. Filter it down, first of all, onto what you need. So if you're using the NHS SNOMED browser on the internet, if you're looking for a procedure, start off by filtering things just to be procedures, because you know what you're looking for, and then search on how you would normally describe it, using just the clinical language that you would use, and that will 99% of the time find you what you need. Once you've found what you need, look down to the children of that concept as well, because what you might find actually is there is a more detailed concept available for the term that you've tried to use. Just watching Claire's screen here, is to say, if you look for what should we look for? Problem solving. So there's a few things called problem solving, but you'll notice those two ones at the top there. One is a procedure of problem solving, and one is an observable entity of watching someone solve problems. So it's that sort of thing, but use the language you normally use first of all, and then use the filters. And we've also got a webinar you can download, which is just an introduction to the browser and where all the buttons are and where all the features are and how to enable this, that, and the other. So there's lots of stuff there we can also do. But yeah, if you're struggling to find what you're getting, what you're trying to find, and that people are burning out to try and find it, don't just stop. Come and find us and we will help you, and we will deliver you some training, and we can point you towards resources and hopefully empower you to do things. We would also encourage you to share with each other what you are doing, because so often we find that a particular trust or organization is doing something, and then 20 miles down the road someone else is slaving away doing exactly the same thing. It'd be really good to see people come together and create sort of special interest groups, either within supplier user forums or in CCIO networks and that sort of thing, to come together and share some of the burden of this, because one of the things that's challenging is everyone is doing it themselves and everyone feels a bit isolated. But if that is you, or you are struggling in any way, if you email snomed.implementation@nhs.net, we will help you. I think that was all the common things that I've spotted. I will go through the questions again. Claire, I don't know if there's anything you've spotted while I've been talking.
No, not that we'd have time to answer now. We're out of time, unfortunately. But just to remind people, we will collate all these questions, and we'll publish the answers alongside the slides, and let you know when that's been done. So if there's anything that you've asked and we haven't been able to answer it, then we will still do that. So I think I just want to thank everyone for their time. Please use the feedback form. Thanks to Pete and to Jonathan as well for monitoring the chat. Yeah, thank you very much.